Having a topic on respiratory symptoms taken by Dr. RAJAM IYER. We can have ma'am's presentation. We can have it for around 30 to 45 minutes, followed by 15 minutes of discussion. By 4 o'clock, we can have a case presentation followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in. Over to Dr. Sonal.
So good afternoon, everybody. Today we have a very important session on respiratory symptoms, which is very common in patients who are getting palliative care. Not only in palliative care, but in many other specialties, respiratory symptoms are a prominent symptom. So Dr. RAJAM IYER will be handling this session. She's a pulmonologist as well as palliative care physician. She's working as pulmonologist in Bhatia Hospital, Mumbai, and as palliative care physician in PD Hinduja Hospital, Mumbai. She has vast experience in the field of pulmonology as well as in palliative care. Welcome, madam, and it's over to you.
Thank you very much. At the outset, I'm not got vast experience. It's just my gray hair. And please, let's do a little bit of a prayer that all the technology will work. It is my first echo session as on this side, as giving a talk. I've attended many echo sessions. So I hope it all works like clockwork. My aim today will be to talk about the palliative care approach in respiratory symptoms, because I'll wear both my hats as a pulmonologist and as a palliative care physician. There's also some time allotted for discussion. So I request all of you to write down your points so that we can have an active discussion, because more interaction means more learning, and it is more interesting for you and me. I can be a better teacher next time. So please feel free to ask questions, yeah, and make a note of what all you have. So let me start with the presentation. Can you all see the screen?
No, madam. No. You have to open the presentation first.
Yeah, I have opened it and I have put it in the screen mode with the share.
First, you open the presentation in the editable mode, and then share the screen.
That's what I did, Sunil. So
okay.
Open the presentation. 1 minute.
Share.
Share. We just did the trial.
Ma'am, this is not the way, ma'am. This you have actually logged in.
Share.
Share presentation.
Share the presentation.
Yeah,
While clicking on the share icon.
Yes, I've done that.
Can you see your presentation in that folder open?
Which folder?
Ma'am, can you see a Zoom file, like a Zoom folder in which you can see every one of us?
Yeah, that's the desktop now.
Desktop? Yes, ma'am. Desktop.
Yeah, can you see the slide now?
Can share the slide.
Can you see the slide?
Yeah.
Cancel option.
Click on the cancel option.
Oh God, this is why I said we need to do that prayer. But we just tried it now.
Yes, ma'am. You can go the same way we have done it.
I'm so sorry for this. So just, can somebody just run me through what because the slide presentation is open.
Okay, ma'am. Can you see a folder in which you can see every one of us in the Zoom folder?
1 minute. in the Zoom folder. Yeah, I can see you all on the panel.
Okay, in the down button, can you see an option
Yeah,
green?
now I can see the slides. So I can see it on a folder.
Can you see a share icon?
It has come.
Yes, ma'am, we can see it. You
Okay,
can. Yes, yes.
fingers crossed. I behave myself. Okay, so just to let you know, why is it going on before even I press it? Okay. So the reason it, like Sunil said, it's important to talk about respiratory symptoms because today, if you see the number of people affected by respiratory diseases in India, can you hear?
Yes, ma'am, we can hear you.
Okay, shall I continue?
Yes, yes, you can continue.
Okay. So if you see the number of people affected by respiratory diseases in India, this was published in the Times of India, October 2nd, 2017, about a data in 2016. So if you see, why is it going on its own? You can see that between TB, COPD, asthma, diabetes, heart diseases, stroke, etc. So cardiorespiratory diseases account for a large number of Indians affected by this illness. So if you extrapolate it to our population, a large number of Indians are actually affected by respiratory diseases, much more than cancer is. And you can see that a lot of people give importance to cancer as a reason for palliative care, while we need to realize that non-cancer also requires as much importance for palliative care. Okay, any questions? Shall I go on? Am I audible?
Can continue. Yeah.
Okay. So we come to this next thing over the global statistics of how it is in India. It has unfortunately the world's 18% of the world's population, but 32% of disability adjusted life years from chronic respiratory diseases. So India actually has 1/3 of the global burden of chronic respiratory diseases, and it is worsened by the aging population. So there is a report to suggest that the number of 60-year-olds will increase by 300% and 80-year-olds by 700% in the next 30 years. This is the prediction for 2050, which is quite scary because even if the geriatric population do not have respiratory issues, they still, do not have a chronic respiratory illness, but just because of their frailty, their age, they are prone to develop respiratory illnesses and they might succumb to respiratory symptoms. That is why it's important to realize that we need to significantly focus on palliative care approaches in patients with respiratory illnesses. Okay, then one second. Right. So this is what I was telling you, that it's important to actually focus on respiratory conditions because in India we have. So if you come to the first symptom, okay, of chest, what is the first thing in respiratory medicine that it hits you is breathlessness. And just to focus or emphasize on the volume of numbers of breathlessness, we see it is 75 million people affected annually worldwide, of which more than 90% are those with respiratory illnesses, which accounts for more than 65 million patients with respiratory illnesses. The rest, the 50% of the 10 million patients with incurable cancers and 50% of the 23 million people with cardiac diseases suffer breathlessness. So it's not just the pulmonologist who see patients with breathlessness, it can be seen across the other illnesses also where they suffer from breathlessness. Some of the causes, because I'm talking of palliative care approach of treating these respiratory symptoms, some of the causes which we frequently see are those with advanced airway disease like chronic obstructive lung disease or even asthma untreated, advanced interstitial lung disease, like those which affect with fibrosis of the lung parenchyma, congestive cardiac failure for really which we can't do or offer any cure, advanced neuromuscular conditions like motor neuron disease, and obviously complications of cancer. It could be the pleural effusions, lymphangitis carcinoma, treatment with cancer medications which affects, like for example, drug-induced fibrosis, as well as cancer-associated muscle loss, which actually does affect patients who have severe cachexia. So if you think about probably already know about these proposed trajectories of dying, but I'm going to focus on the third part, which is the organ failure, which is what most of my patients with COPD or congestive cardiac failure or patients with advanced lung disease have. So if you see these patients live for a long period of time, somewhere between 5 years to 10 years, with high symptom burden, and every time you can see that they get admitted with an acute exacerbation, their quality of life dips. So these patients are the ones who keep getting admitted with acute exacerbations. Physicians are trained to treat their acute exacerbations, but how they lead their quality of life after they go home, and how it's a deteriorating function, not just physically, emotionally, vocationally, socially. These people slowly die a social death even before physical death. So we need to focus on this group 3, which are organ failures and the ones that actually lead to high burdens of respiratory symptoms. So if you want to assess breathlessness, first of all, you need to know the type of breathlessness, which means you need to know there is acute breathlessness, which is mainly dealt in the emergency. There's acute and chronic breathlessness, and then there is chronic breathlessness. Each of this plays very differently on the patient's mind, as well as the physician's mind, as well as the family's mind. It's important, therefore, to classify your patients, and most of our patients who come for palliative care are the ones who fit into chronic breathlessness. There are many scales available to assess breathlessness. The New York Heart Association is meant for patients with cardiac conditions. The Modified Medical Research Council is for patients with chest conditions, and those with Borg scale are for essentially to assess patients who get breathless because of deconditioning. And the deconditioning could be either because of the heart, or because of the neurology, or because of the kidney. So any of the organs which are affected, advanced in a severe state, can lead to the patient becoming more bedbound. And sorry, is there a problem?
Yes, ma'am.
We lost the presentation.
Yes, ma'am. We can't see the presentation now.
So what happened?
So, ma'am, can you try sharing it once again?
Sure. Sorted?
Yes, yes, yes.
Okay. So these are the various scales of assessment which is available, which we use it. And as you know, these are the New York Heart Association classifies as class 1, 2, 3, 4. And class 1 is ordinary physical activity does not cause any undue palpitations, breathlessness, or angina, which are associated with cardiac symptoms. Class 2 is ordinary physical activity affecting it, less than ordinary, and those which occur at rest. But if you see, the respiratory physicians use the Modified Medical Research Council, which classifies breathlessness as grades. Now, this is just to help you put these patients into various categories so that you can optimally treat them. But essentially, you really need to focus on what this breathlessness does to the patients and how it affects their activity of living. So just to reiterate, what is Modified Medical Research Council? It is grade 0, which is breathlessness on strenuous exercise, which probably most of us will have if we do something which we are not used to. Grade 1 is short of breath when hurrying or walking up a slight hill. Then if grade 2 is when you walk slower than others of your same age when walking on the same level ground. Grade 3 is when you stop after every 100 meters for a few minutes. And this is compared to people of your same age, race, height, sex. And grade 4, when you're too breathless to leave the house of washing, dressing, etc. So this helps you classify your patients as to how severe the breathlessness is, because you know, all of you are doctors, you know that definition of breathlessness is something that the patient complains of. It is not something that you can see, it's very abstract. So it is an uncomfortable, abnormal sensation, what the patient experiences. And to be honest with you, we need to believe what the patient says and therefore help the classification so that we can treat the patient better. When you have a patient who complains of breathlessness, you need to go through this basic of evaluation, which is detailed history, which can start with with occupation, smoking history, how long the symptoms are. I don't need to go into the details of how to take a detailed history. You people are all very experienced doctors. The next comes to clinical examination as to how you will examine the patient for respiratory as well as cardiac, way to sit, make the patient sit. Ideally, it should be on a chair so you can see the entire lung. More of the lung is at the back. Then you do the general examination. Then you do the inspection, palpation, auscultation, and percussion and auscultation. The basic investigations you need to do is a chest X-ray, electrocardiogram, pulmonary function test, bronchodilator reversibility, chest echo, high resolution CT scan, as well as an arterial blood gas. This is essential list if it's possible. The last two I have written at the end. So in smaller centers, if it's not possible, it's okay to come to a diagnosis with the first top few, because you will largely know if this patient is a cardiac patient or a lung patient, because these are the ones which have similar symptoms. Okay, so it's now when it comes to breathlessness, and we and palliative care go beyond the physical symptoms. The issues of patients with breathlessness, especially the ones we see, are the chronic breathlessness. These are because patients with chronic breathlessness have activities which are limited of daily living. They are completely dependent on family. Therefore, they have a loss of role. And like I said before, they are socially isolated, which means they die a social death because they're bedbound and housebound, probably on oxygen or non-invasive ventilator much before they are physically die. And therefore, it adds to their frustration, anger, depression, and they also have a fear of death. And the breathlessness is worsened by anxiety and panic. So there's this beautiful model which has been described in the primary care respiratory medicine, which is the breathing, thinking, functioning module. So imagine a patient who is breathless because of COPD or ILD, and he's been gradually worsening over the past 2, 3, 4 years. Imagine how it would be to slowly become not able to do most of the things you like and losing your independence. So first of all, the respiratory rate increases and your accessory muscles of respiration are in use. Because of that, there is constant hyperinflation, inefficient breathing that worsens the breathlessness. This triggers the thought process. Am I going to die? Feeling of panic. How will I die? Will I choke to death? And all those thoughts and experience of previous admissions to hospital or visiting a doctor. And all this directly affects the fact patient therefore gets scared to even walk to the toilet or even go out to have a dinner or a meal with his family on the dining table, because that small activity completely makes him breathless and it further makes him deconditioned. So this is the vicious cycle that our patients get caught in, which is beautifully described in this diagram, and it is self-explanatory. And therefore, we need to address each of this when we treat patients of chronic breathlessness syndrome. So this was a term coined by Miriam Johnson and David Currow, who have done extensive work in chronic breathlessness. And how have they defined breathlessness as in chronic breathlessness? Is that breathlessness which is persists despite optimized evidence-based treatment of whatever the underlying pathophysiology, be it cardiac, be it muscle wasting, be it COPD, ILD. So when the patient continues to be breathless despite being on full treatment of the original condition, that breathlessness which contributes to his physical limitations and affects him in a holistic manner, psychologically, socially, spiritually, etc. And it's irrelevant how long this breathlessness is present, because for that patient, his quality of life is severely affected. So this is what we will deal with mainly. How do you deal these patients of chronic breathlessness? There's enough evidence to suggest that the non-pharmacological interventions play a big role. Now, as doctors, we often neglect this part of treatment for breathlessness. And it's extremely important to try and talk to the patient, find out what his fears, what his anxiety is, and reassure him. It's also important not to give him unrealistic hope, saying everything will be all right and we will be able to cure your breathlessness. We need to explore his values, beliefs while talking to the patient, as well as simultaneously counseling him, because there might be various other reasons that he is worried about. For example, finances, what will happen to his family, what happens to his children. So these can also contribute to worsening the chronic breathlessness. The next point, of course, is physiotherapy, where we talk of rehabilitation, relaxation techniques, breathing techniques, to efficiently use and effectively use the accessory muscles of respiration, how to position these patients when they have an acute episode, and also if you can write and give them step-by-step instructions of how to deal an acute event, so they have something to hold on to. As well as there's been research about how you can keep these patients next to a window, or keep giving them loose clothes, or a fan blowing directed. So many of my patients also say that that gives them a sensation of removing of air hunger. If you blow a handhold fan just over their face, and they feel much better with that. Along with that is patient support groups, because somewhere when they talk to other patients with similar conditions, they also feel reassured that they're not alone. So acupressure, acupuncture can be tried, though I haven't used it, but music therapy, some distraction, pet therapy, these are other non-pharmacological things that you can focus on. Please keep this in your bag, and it really makes the patient and the family that they're able to do something to offer comfort to their patient whom otherwise they don't have any cure. Coming to the pharmacological ones, I'm sure all of you are familiar how we treat airway diseases with bronchodilators, mainly inhaled, as well as oral bronchodilators when the condition is severe, steroids when there's an acute exacerbation, nebulizer if the patient is not able to take inhalers, oxygen when there is documented hypoxemia or a low saturation, antibiotics when there is an evidence of infection, high-grade fever, yellow sputum, or when the X-ray shows a pneumonic patch, and antifibrotics which are focused in interstitial lung disease, because it is known to prove to delay the fibrosis by using drugs like pirfenidone and nintedanib, which may not be in the purview of a physician who practices in the rural area, or for a family physician, but it's important to know about it. The one big ammunition that palliative care physicians have, and we do not use it well, is morphine, about which I will talk later, especially the role of morphine in chronic breathlessness syndrome. I know all of you have heard about morphine in pain, and you're very well versed with using it confidently. I urge all of you to use it in your patients who have chronic breathlessness syndrome, because it makes a world of difference to them. The other thing that we commonly use is non-invasive ventilation, which is a mask, which we call as BiPAP, which can be used and is effective in relieving breathlessness for a period of time in patients, especially in patients with motor neuron disease, where they have muscular atrophy and the diaphragm is non-functional. This is also because invasive ventilation is something that these patients with chronic breathlessness syndrome and advanced lung diseases have a very poor outcome, and therefore it is not something that we should be talking to patients who are in palliative care. So what does morphine do? There's a lot of opioid phobia, and I want to remove some of that. The mechanism of action of morphine for the respiratory conditions is that it reduces the ventilatory response to hypercapnia, hypoxia, and exercise. It reduces the sensation of dyspnea and breathlessness. So it's very important to tell your patients that it does not change the airways or the lung. It only makes the patient more comfortable and therefore able to do and carry out small activities which give the patient small pleasures, like walking to the toilet with less problem, going and sharing a meal with the rest of the family on the dining table and not eating in his room. So like everything in palliative care, we always almost start low, go slow, and slowly titrate with 25% increase weekly. So how do we do that? This is a nice algorithm to show you how we do it. So when there is breathlessness, we start with a really small dose of opioid, which is 2.5 milligrams. Ideally, we start 12 hourly. If you're confident you have a good review with the patient, you can start 6 to 8 hourly, or even 4 hourly, but you have to have a good communication with the patient. Like you all know, you have to start opioids with laxatives always. This is along with, of course, oxygen if the patient is hypoxemic. So you start with the low dose opioids. You almost always continue the other treatment like bronchodilators, steroids, nebulizers, etc. If you think there is anxiety associated, you can add have medications like a benzodiazepine or lorazepam. And if you think there is panic, you can also add midazolam. So ideally, how we start it is a low dose. You review weekly, and you slowly increase the dose if there's response by 25 milligrams, for 25% every week. And there is literature to suggest that we normally don't exceed 30 milligrams. In the West, they use sustained release. However, in Bombay, we have only immediate release. So we use small 2.5 milligrams first 12 hourly, review to 8 hourly, 6 hourly, and 4 hourly. And then, depending on the number of SOS doses the patient is using, we then modify to the base dose and keep increasing the dose. And we do not exceed to more than 30 milligrams. So this is an interesting chart which I came across about the myths about morphine, about people being addicted to it, and how long should I take it? Should I stop it? And I don't have pain. I'm not at the end of life. So these are the myths that you need to realize, that morphine can be used orally in chronic breathlessness. It can be used subcutaneously. It can also be used as a continuous infusion in patients who are towards the end of life, which I will talk about in a bit. And it's not only for pain. Please remember, it works brilliantly for patients with chronic breathlessness, and it almost always makes them feel a little bit better, to make them do things that they enjoy. So it is a wonder in or hypercapnia, which is rise in carbon dioxide levels. It is a safe drug when used in low doses, and oral or parenteral is way better than using nebulized morphine. So coming to terminal breathlessness. Now, this is a very distressing symptom. It's almost always seen in most patients who are about to die, not just respiratory patients. It's also distressing for the family. Again, you must have heard the famous saying by Dame Cicely Saunders, where the memory of the ones who die is etched in those who live on. So that journey of how the loved ones pass on to the next is very important for the patient and the family to be comfortable. And it helps to recognize terminal breathlessness and treat. And usually we start an infusion of morphine and midazolam. If the patient is agitated, we add haloperidol. Otherwise, it's a slow infusion given over 24 hours, so that this is the minimum dose required to keep the patient comfortable and also the family comfortable. The intent is to keep the patient comfortable. The intent of treating this with this kind of palliative sedation is not to cause a harm, or it's not euthanasia. So this communication and this documentation is extremely important before you start this infusion. So this is about midazolam, about how you can give it to treat anxiety, about we give about 2.5 to 5 milligrams subcutaneous in emergencies. And it's important to read these things so that it is not clear in your head about what you're giving it, how much you're giving it, and when you use it. So a little bit about palliative sedation. I think it's important because some patients are very scared about how they're going to die, and whether they will be breathless, whether they will be choking, whether they'll be unconscious. So it's important for us physicians to be able to explain to them. The physician's responsibility is for those patients who are hopelessly ill and they don't want to experience those distressing symptoms. It is not to hasten death. It is not euthanasia. Therefore, you must understand that these patients are already probably on a bit of steroids, opioids orally. So you need to titrate their use. And maybe these are for patients who are very few number of patients you'll actually need to do palliative sedation. We need to communicate and document this extremely well before you use it, because there's a very gray line between palliative sedation and causing direct death. But like I said before, the intent is to give the patient comfortable. Patient has expressed desire of not wanting to be aware of symptoms. Therefore, we choose this route. Again, death is imminent. It could be days or hours only when we decide to use palliative care. So selection of patients for palliative sedation is important. Communication is important. Documentation is important. And supporting the patient and the family through this journey of 2 days or 3 days or few hours is extremely important role of a palliative care physician. So this comes to breathlessness. If there is no question or you want to wait for the questions to the end, I can go on to cough. Any questions on breathlessness?
Ma'am, I think we can take all questions at the end, ma'am.
Okay, fine. So coming to the next common symptom that we see in respiratory OPDs is cough. It is actually a normal protective reflex. So the cough receptors are present in the nose, in the upper airways, in the chest, in the ears, etc. So it actually prevents foreign body from entering the lung. So it's a protective reflex. But when it does become pathological and distressing, when the reflex is ineffective, and it starts affecting the patient's daily life. So activities of daily living like sleep, eating, and even going out. And it can be a major complication or complaint even in patients with cancer. So, like I said, the causes of cough is not restricted to respiratory. It could be gastric, you must have heard of GERD, or cardiac. Very often, patients with congestive cardiac failure complain of cough and breathlessness. Drugs, also drugs which are cancer drugs or drugs, antihypertensive like ACE inhibitors, post radiation, or sometimes when patient is psychogenic cough is also a known entity. So, how do we treat cough? Again, when you ask the history of cough, you have to be very specific about dry cough, wet cough, color of the wet cough, timing of the cough, whether cough comes when immediately on lying down, whether cough is a throaty cough or a chesty cough. So these are the details in history which will actually help you to diagnose from where exactly is the cough coming. For example, if a patient says it comes immediately on lying down or bending, or there is a throaty cough with a change in voice, or the patient has a heartburn, it's more likely to have GERD symptoms, and your direction should be completely different, because then you need to advise lifestyle changes, early dinner, light dinner, 3-hour gap between dinner and bed, and a little stroll after dinner. But when it comes to a cough which is with chest pain, breathlessness, previous history of cardiac, you know then this is probably a left ventricular failure. So it's important to know where is the cough originating before you treat it. So if the cough is essentially from the respiratory tract, then the things we do besides continuing medications for the underlying condition is also give antibiotics and give nebulized saline to make the cough easily expectorated. And please remember that intractable cough, like you see in interstitial lung disease, also responds very well to opioids or codeine being the little weaker opioid. But unfortunately, codeine syrups are now not available in Bombay. So we do give patients with intractable cough, for example, those with interstitial lung disease, very commonly we do use opioids. So the pharmacological treatment for cough again is optimize inhalers. So check the technique, add nebulizers if the patient is not able to use inhalers with a spacer, opioids, especially for those patients who are also breathless at rest. And also when there is a component of anxiety, please use either the SSRI citalopram or benzodiazepine. There are certain other acupressures also which people have talked about in order to treat the cough, which also seems to be beneficial as a non-pharmacological aspect, besides of course using lozenges, homemade therapy like hot water, honey, and positioning the patient where the patient feels much relieved and there is less cough compared to previous. So the things we use for oral morphine, I've already told you how we use for breathlessness. The same principle is for cough. In codeine, we use 15 to 30 milligrams of codeine syrup, which can be used 3 to 4 times a day. Please remember, when codeine causes constipation, it's important to prescribe laxatives. The other interesting thing about treating chronic cough is the use of gabapentin, which has worked again very well in patients with interstitial lung disease. Also, gabapentin has a little sedative effect. So when used in the night, patient's sleep is not disturbed and the cough doesn't seem to disturb the sleep. And in a doses from 300 to 600 milligrams 3 times a day, it can be given in intractable cough. And it has been shown to be very useful for patients where you are not able to get morphine, or as an earlier step to morphine, you can try to use gabapentin. Then coming to the next symptom, which is breathlessness. So,
Dr. Rajan, can you hear us?
Palliative care is the recurrently filling pleural effusion in a malignant effusion. So that is what we should focus on. So small effusions you really don't need to do anything. You can observe or give a short course of steroids to help the absorption of fluid. If the patient's prognosis is less than 4 weeks, it's an approximate prognostication, then you should be doing less interventions like probably aspiration. But if you feel this patient's recurrent pleural effusion and his Kornofsky scale is good and he's going to live more than 4 weeks, then you can attempt to put interventional things like a small pigtail or an intercostal drain, tap it dry, and then you can use talc fluorodesis so that the patient lives the rest of his life comfortably. If the patient's prognosis is even better than 1 or 2 months, then you should do a thoracoscopy, which is an invasive procedure, and do a talc. Otherwise, you can also plan a long-term indwelling catheter if a patient is not willing to undergo a procedure for treating the recurrent pleural effusions. Again, depending on the cause is how you treat it. Malignant pleural effusions are the most complicated, and it also best managed depending on the severity of the effusion, the performance status of the patient, and how well he's responding to chemo or radiotherapy and radiation. So you have a wide variety from observation to aspiration to a small pigtail and to a thoracoscopic drainage or a long-term pigtail for managing recurrent pleural effusions. Okay. The other symptom we should touch upon is hemoptysis, because again, it is a very scary thought, because patients with hemoptysis don't just die of exsanguination, but they actually choke in their own blood. And that can be very scary. And sometimes we have noticed in tuberculosis, especially, that patients can have one large bout of hemoptysis and just aspirate that and die. Besides tuberculosis, even lung cancer is a common cause of hemoptysis, and up to 3% of hemoptysis is fatal, because it's the bronchial artery which ruptures, and it comes at the pressure of the blood pressure. So the bleeding is at a torrential high rate, which can be quite scary. If the patient is not mentally prepared, it can be a very scary sight for both the patient and the family. So the interventions for palliative treatment of hemoptysis could extend from radiotherapy to palliative external beam radiation, or symptoms which are more invasive like brachytherapy. So if you have an endobronchial tumor, that can be radiated, or there can be cryo done, or bronchial artery embolization, or that particular bleeder can be laser can be given so that bleeding is stopped, or a radio frequency ablation. So again, we have a wide variety of treatments available for palliative treatment of hemoptysis, and these are interventions which are done both by chest physicians as well as the radiologists, and the radiologists do the bronchial artery embolization very well. Only care you have to take is sometimes in certain patients the spinal artery is a branch of the bronchial artery, and if you embolize that, there are some patients who end up in a worse situation. The bleeding might stop, but they also might have the spinal artery which is embolized, which is a dangerous side effect, and we have to be very careful before we suggest bronchial artery embolizations in such patients. So the management of that is, it's very easy for us as doctors to say, don't worry. It's very unlikely that if you're having a patient with a large amount of hemoptysis, that he will not worry. So you must acknowledge his concern and say that I can very well imagine what you must be going through. And like I said, if there is any correct the correctable is a mantra in palliative care. So you must correct the bleeding diathesis. And then, of course, you can use tranexamic acid. Very often, we also sometimes use the services of our ENT specialists and get a rigid bronchoscope so that we can inject the tranexamic acid intrabronchially, so that we can do the other steps like ablation, like laser, because with the fiber optic bronchoscope, so much of bleeding actually blurs your vision. So you're not able to actually do anything, but we are able to, sometimes what we do is use the ENT to use a rigid scope and pass the flexible fiber optic scope through the rigid so that the airway is maintained. Hiccups, another common thing because of contraction of the diaphragm, therefore comes under the purview of a respiratory physician. It can be transient, it can be persistent, and it can be very distressing. Most common causes, of course, the reflux or the acidity, and simple things that you can do is, of course, like hold breath or neutralize the acid. But if you feel you need to investigate more, then there are certain investigations that you can do, but it's not the purview of a palliative care concept or an environment. The drug management is usually to decrease gastric distension, to decrease the hiccups, or you can use central suppressants like baclofen or anti-epileptics, and metoclopramide, as well as other medications like haloperidol and midazolam also help in controlling the hiccups. Have I gone overboard? So the management, again, non-pharmacological, is like nasal stimulation or respiratory maneuvers like holding breath. And what is important to realize is that I have just given you a snapshot of all the respiratory symptoms that you can see. The basic ethos remains the same, that you really need to evaluate with great detail of your history, the clinical evaluation, come ask questions so that you can actually come down to where exactly are these symptoms coming from, do the basic investigations and give patients maximum treatment so that they can live a life peacefully, especially when we talk of a palliative care setting. Thank you. I'm open to questions. Should I do stop share? Hello? Questions? Are we ready for questions? Yes?
Yes, Dr. Narendra, you can. Please unmute yourself.
Dr. Narendra, can you?
Yes,
Yes,
yes.
yes, Doctor.
Please.
Excellent presentation, madam, and a very good presentation, madam.
Thank you.
And flow of English is very excellent. I'm very happy to learn that gabapentin is being used for hiccups, which I don't know before. And another thing, madam, one small doubt that you want to start by 2.5 mg 12 hourly. But is it sufficient for the? I mean, half life is around 4 hours, no, madam. So is it sufficient, or we need to go by 4 hourly only?
So thank you for that question. The reason we start 12 hourly is also because most of our patients we start on OPD basis. So we don't have a regular review. And sometimes some patients, because as it is, there's a lot of opioid phobia for patients with breathlessness. Patients, family, as well as the general physician and the other pulmonologists who refer patients are scared about starting opioid in the first place. And when you tell them that you can give them every 4 hourly, then the compliance actually becomes they don't give the patient at all. So ideally, because the patient should not be deprived of the benefits of this low dose morphine, I almost always tell them, let's start 12 hourly. Report to me how the patient feels in the next 2-3 days, and we can slowly increase. So very often, close to 70 to 75% of patients feel really good because they sleep well, the cough decreases. So almost always I tell them, start 2.5 milligram 12 hourly, keep an extra dose of 2.5 milligram, so that in between, if the patient feels the way he normally feels breathless or something, you can try to give an extra dose. There is no harm. So the reason I start so low, go slow, is to build their confidence and also to feel that I am not here to kill the patient. I don't want to make the patients. Also, some patients feel they want to be awake and comfortable, not sleeping all the time. See, because morphine, very often patients are not given morphine in the end of life only. A lot of my patients are on morphine for a good 8-9 months orally. So they want to be able to do their daily activities easily, which is why we start them on such a dose. Plus, if you are able to start a patient inpatient with morphine, then you can give a little bit more frequent dose. Because abroad they give 10 milligrams sustained release. So they give it 10 milligrams in the morning and 10 milligrams in the night. So it's actually covering the 24 hours. But we don't get sustained release. We have a lot of obstacles, inertia in the minds of doctors, patients, families about morphine. If you say 4-hourly, I've had enough educated patients who don't start at all. And they really deny the patient of something small like comfort feeling, like small speak full sentences. Because there are patients who say, I enjoy talking on the phone to relatives. I can't because I'm so breathless. So the least you can do, therefore, is to see to it that the small pleasures of life they're able to do with little less discomfort. So just to be on the safer side, I start. If you have a setting where you can start 4-hourly or 6-hourly, you still need to monitor. And also, obviously, even those low doses, please give laxatives, because patients with respiratory distress have no strength to push when they have constipation. They, you can have a problem in, if you do, some people say such a small dose of morphine also can cause constipation. So we really need to give laxatives in such patients.
Madam, does this benzodiazepines and morphine combination act on the accessory muscles or the interstitial of the lung?
It acts on the central. That's why it decreases the sensation of breathlessness, because the lung doesn't change, the interstitium doesn't change, the interstitium is incurably fibrosed, the airways are irreversibly damaged. It acts centrally to decrease the sensation of breathlessness, decreases the respiratory drive, because the respiratory center is in the brain. So the depth of respiration increases. Therefore, some patients actually even the gas exchange improves. Because the depth improves, the gas exchange improves, and the oxygen requirement can become less. From say 5 liters and 6 liters, sometimes patients say, now I can do with the 3 and 4 liters of oxygen. So the mechanism is central.
Thank you very much.
Thank you.
Anybody else?
You can either raise your hands or unmute yourself and speak.
Madam, there are many scales, as you told, to rate the breathlessness. So, which one do you commonly use? Is NYHS specifically for cardiac patients, or is it used by pulmonologists also?
So NYHA is specifically used by cardiologists. So congestive cardiac failure patients, we stick to New York Heart Association, because they also classify it as class 1, 2, 3, 4. And in for chest physicians, we use the modified medical research, because they're also grade and they're much more than NYHA. So we also have a grade 0 and we have a grade 5. And the difference is also that in the chest MMRC, we actually compare it with people of their own age, height, race, sex. So that is what is the benchmark. So if you have two 30-year-olds, one is breathless on climbing stairs and one is not, then that is also taken into account to classify these patients. So respiratory physicians use MMRC. Having said that, when you have to test deconditioning, you can also use the Borg scale, which is what we use when we do a 6-minute walk test, which is very specific for interstitial lung disease, because it actually, we make the patient walk for 6 minutes, not fast, as far as the patient can in 6 minutes, and we document the desaturation of oxygen to prove to the patient that he requires oxygen during activities. So that time we use the Borg scale for breathlessness of mild, moderate and severe breathlessness. So you can also use a visual analog scale for patients with breathlessness. There has been research done just like pain, where patients say initially I was 8 or 9 or 7 without morphine. With morphine, it has come to 3 or 4. So I have done this on a small group of patients in the OPD just because it's less time consuming. But please note that in patients in a palliative care setting, your MMRC might not change drastically with the treatment, but it is the functional ability of the patient, because you're not doing anything to the underlying lung. The underlying lung is going to remain the same. What we manage to do is palliate the symptom and therefore give the patient a decent quality of life in order that he can do simple small pleasures.
Is there anybody? Madam, will you be more cautious in COPD or interstitial lung disease than advanced malignancy people on starting morphine?
So I think the indication in advanced COPD, airway disease and interstitial lung is breathlessness mainly. And in cancer, it could also be a combination of pain and breathlessness. So if the patient's main cause or main symptom is breathlessness, you should start low, go slow, and keep in regular review with the patient or his family physician to increase the dose of morphine, because here in Bombay we have only immediate release. So ideally you do reach up to 4 hourly, but very, very slowly, because you really need to impress upon the patient and the family, like I said before, that this drug works. This is not given to kill the patient or cause the patient carbon dioxide retention. Nobody has an experience of using it in a palliative setting, which is why we have to slowly build that confidence, and therefore it's better to start low, go slow, rather than giving it 4 hourly. Therefore that's a caution I will also tell people who send patients home on morphine. It's important therefore to emphasize on that fact.
So there are various regimes described for starting morphine in patients with advanced breathlessness, and even some people starts 1 milligram per day and then gradually increase it over a 10-week or 12 weeks period up to 5 milligram per hour. So
Correct. I just wanted it to be much more user friendly, especially in an outpatient setting. See, in an inpatient setting, you have much more control, and it is much more easier to review the dosages. But when you're sending the patient home, like I suppose most doctors who are in the group do, then it's better to have a direct starting low dose, and how to review and teach them how to increase it by 25% every week, and review whether they've taken extra doses and incorporate that into the base dose.
Dr. Hema?
I wanted to ask one thing. How much desaturation will you allow in a chronic patient before asking him to take oxygen routinely? Like I have seen these patients many a times, they have practically low SpO2 levels, but they are not so uncomfortable. Like they know their limit and they manage. And suppose he's dropping down to 88, 87, but not symptomatically uncomfortable. Should he be advised oxygen routinely?
Okay, very good question, because I think oxygen is one thing that's abused by everybody, patient,
Yes.
family, GPs, everybody. So the thing about oxygen is that oxygen is a drug. Excess oxygen is also dangerous because it causes nascent destruction of the lung.
Yeah.
Third thing is, ideally in patients with advanced lung diseases, we ask our patients to maintain levels between 88 and 92. The reason we ask the patients to maintain 88 and 92 is below 88, there is a strain on the heart, the brain, and the kidney. So very often, even if the patient is asymptomatic, if it drops to 87, 86, cumulatively it affects the heart, and you have a right heart pressure which increases, and the patient is in potential cor pulmonale and right heart failure, which is also worsening his breathlessness. Because a low oxygen is a potent vasoconstrictor, and it immediately causes the back effects to the pulmonary artery hypertension. So the best way we do is ask them to maintain between 88 and 92. This leads to a next question, that patient keeps checking his oxygen, which is another obsession, which we don't want. Therefore, when we evaluate patients with chronic respiratory diseases, we do a 6-minute walk test. What does the 6-minute walk test do? It basically measures the oxygen when the patient starts walking, that is at rest, and during those 6 minutes, and how much he desaturates. This is indicating the fact that patient requires oxygen during activities like walking, sleeping, eating, toilet, bath. So in an advanced lung, it's almost 24/7. Unless the patient is just sitting and watching TV, he probably doesn't need. But 6-minute walk test is a good indicator to tell which patients to keep oxygen and to use oxygen at what time. Alternatively, you can, in the initial stages, we do nocturnal oximetry, say to see if the patient is desaturating only during sleep. So that time you use oxygen and maintain the levels between 88 and 92. We don't need a 97, 98 in a patient with advanced lung disease. You're only causing more harm. We need 88 to 92 so that the rest.
Exactly.
Yeah, does that answer your question?
Yes, because many a times I still remember getting a call for a patient, of course, because I'm an anesthetist and intensivist, that somebody, chronic lung failure on home oxygen, kindly adjust their mask and whatever, because or change to positive pressure type, because he's not going above 92 or above 93. So which I found very funny. I said, if he's comfortable, why do you need to 95? But in general, even physicians have this notion that he should maintain above 95.
And also going below, say, suppose he has 87, 86 at all times, that contributes to the vasoconstriction. So that also is not allowed. So sometimes it's best, therefore, to tell them, please use during activity. Very often patients say, but how can I go to the toilet with the oxygen? So the oxygen concentrator, you can ask for 100-meter tubing. The concentrator can sit in the room and you walk, go to the living room, go to the toilet, because the maximum desaturation happens during a bath. If you've seen, many elderly people also feel exhausted after a bath, and toilet. Urine might not be still so much, but toilet is with. Which is why I keep reiterating, when you put morphine, laxatives, because the toilet is extremely difficult for patients with advanced lung disease.
Right. Thank you.
Thank you.
Dr. Veena?
Sorry, I missed so much of the class, but still I have one question.
Sure.
In pediatrics, we use, for those people who cannot walk, for those kids who cannot walk, we use this oral test, ask them to count from 1 to 10. So can we use something like that in adults also? Those who cannot walk, can they count maybe from 1 to 20 and measure the SpO2 and see if the oxygenation requires?
So 1 to 10 counting is done for muscular weakness, ma'am, not the airway. For example, motor neuron disease patient. We tell them to take a deep breath and count 1, 2, 3, 4, 5, 6. That's the breath test. So for airway and interstitial lung, where the lung parenchyma and the lung air, it's probably not a very ideal way to test the breathlessness. So another way of doing it is just, for example, in adults, it is not a very, correct way of doing it, because adults have reserves. They can use accessory muscles of respiration and still be able to count 1, 2, 3, 4, 5, 6. You understand? So it's a bit erroneous in adults. Even if you cannot walk for 6 minutes, even if they walk, you can measure it when they walk from table to toilet. That much distance also they might be desaturating. So it's ideal if you can do a 6-minute walk test much before they become so chronically ill. Or even the activities of daily living, you can measure and see that the oxygen levels are falling. So you don't necessarily need to do at home. But 1, 2, 3, 4 is usually saved for muscular conditions like MND, where the diaphragm doesn't hold the contract at all. That's when we use this, because that is the indication for us to start using the NIV in motor neuron disease patients.
Thank you. In asthma, we do that for childhood asthma.
Yeah, that is speaking full sentences. Is it 1, 2, 3, 4 or speaking full sentences or monosyllables? That's what you do in asthma exacerbation. Like We say able to speak full sentences, speaking only monosyllables. That is an acute exacerbation of asthma. The concept here is chronic breathlessness. So it's not an acute event. These patients are almost always breathless, like 24/7.
Thank you.
Thank you.
Dr. Narendra, do you have any more question? No. Thank you. Anybody else? Okay. So we just now heard that breathlessness is a very common symptom, and there are it is not only because of lung diseases, but because of many other problems, heart diseases, as the people getting old. So many problems can cause breathlessness, and it is important to find out the reason. And get a detailed history, investigate. There are many investigations which can be done. And if there are anything correctable, we have to correct it. And in case of refractory breathlessness, we can use opioids in small doses, which can reduce the breathlessness in most of the patients. So maybe we can start with the small dose and gradually increase the dose. But usually the dose requirement of morphine used to treat breathlessness is less than that of required for pain management. So usually it is less than 30 milligram per day, and maybe occasional patient might require a little bit more dosage. So thank you, madam. And we will move on to patient story, which will be presented by Dr. Narendra.
Dr. Narendra, can you unmute from your end? Yes, yes.
Okay, good afternoon, everybody. Maybe after Rajam madam's presentation, my English would be a little bit dull, so kindly bear with me.
Not at all.
I kindly request Rajam madam to be in the session because I am going to talk about something like TB today.
I am here only.
Next slide, please. So it's a patient of 45 years male who is diagnosed with HIV and HbSAg and is also suffering from tuberculosis. The presenting complaints of distension of abdomen and severe pain in the right chest and the shoulder, and is additionally is also having bleeding per rectum. Next, please. And regarding the history of illness, the patient knows that he is HIV and HbSAg status since 2011, and he is taking treatment regularly from the government hospitals. In Andhra Pradesh, for both HIV and TB, we have a continuous support from the government. And he recently developed distension of abdomen and swelling of both legs and bleeding per rectum occasionally. He is also suffering from severe pain in the chest below the clavicle, which is radiating to the back and the right shoulder, which keeps him awake the whole night. The pain is not getting response from even tramadol and gabapentin, so he came to us for help. Next slide, please. He is moderately built and moderately nourished patient with a normal BP of 130/80 and pulse rate about 80. And on examination, there is little bit fitting of edema on both the legs. And per abdomen, there is a distension of the abdomen with fluid thrill, signing that it is having ascites. And per rectum, when examination was done, where I found it is 1st-degree hemorrhoids. Next slide, please. And the treatment and regarding the significant investigations, he is on ART, that is tenofovir, disproxil fumarate 300 mg and lamivudine 300 mg and efavirenz 600 mg. It all comes in one tablet, which is given by the District AIDS Control Society. And is also taking anti-tuberculosis medicine, that is rifampicin 150 mg, isoniazid 75 mg, pyrazinamide 400 mg, and ethambutol. Even this is also combined in one tablet only. So we have done CBP, RBS, and LFT also, and all of them are except TC, all of them are normal. LFT is also normal except for the alkaline phosphatase. There is rise of alkaline phosphatase. Next slide, please. The psychosocial aspects is this patient is living with his mother. She is around 65 and very obese and cannot even work on her own. She can't even move around the house. She's such an obese lady, and he was forcibly married to his niece only. But as if this fellow knows that he is HIV and HbA positive, he kept her at a distance. And after living like that for around 6 years, they got separated, and now she went away and she is living with her parents now. Because of his temperament, the patient brother and his wife used to be also stay in the same house. But because of the patient's ill temperament, they have to move to another place. So after they have gone, nowadays he is not getting sleep and is complaining more of pain and severity in the night time. Now in recent days, he developed a fear of death, and signs of deprivation is clearly seen in the patient. Next. So regarding the medications that he is taking ART medication, that is for HIV and anti-TB medications. And he is also taking Ultracet BAD and pantoprazole and Udiliv, ursodeoxycholic acid, reheptin, that is Silmarin, and B complex. There is lot of pill load over here. Next, please. So now the problem comes is, now already there is a huge load of the pill load. Now still he is feeling the pain. So what are the pain medication could we prefer for this patient? And what may be the cause of the ascites? Is it is to the drugs, from the drugs, or because of the HbA through which the liver automatically get little bit damaged? Next slide, please. Regarding the summary, this is a 45-year male with known HIV, HbA and active tuberculosis, all under government treatment. All under government treatment, which I have mentioned, is because we can't change the schedule, and in Andhra, the TB medicines cannot be written by private practitioners. Only the government will supply for it. Because he's taking from them only, we don't have any other option to change the drugs. And he has developed the distension of abdomen, pedal edema, and severe chest pain and shoulder, which is so severe that he was unable to sleep and is now worried. Next, please. And why I have presented this case is, what may be the cause of the chest pain and right shoulder pain? And can we consider this in the palliation treatment? Can we prescribe morphine? If so, with what dosage? These are the key discussion points which I would like to discuss with you. Thank you. That is my small and humble presentation. I hope I have not done much grammatical mistakes, and excuse me if there are any some mistakes. So can we discuss regarding the ascites and the liver damage? Why alkaline phosphatase has raised? As far as I am concerned, tenofovir will also cause liver problems, and rifampicin will also act on the liver. So that are all the 2 points which I have got, but I don't know because the patient is completely in the government schedule. So what best shall I have to advise him, and what is the next step to control the pain?
Sunil, do you want to go? First of all, congratulations that you're a surgeon. So that itself is hugely in my appreciation list. We find very few surgeons who have the time and the heart for palliative care. So congratulations on that. And please don't apologize for your English. It's important to communicate. That is what is most important. So does anybody want to start answering the questions?
Anybody from the group have any comments? There are 3 questions. What might be the cause of chest pain and right shoulder pain? Can we include this patient under palliative care? Can we prescribe morphine? And if so, what dosages?
So if you want, I mean, I can start by just saying this, that about can we consider this in palliation? So all medications and all diseases come under palliation. Because palliative care is not just for end of life, it is not for terminal, it is for all those patients who have chronic, incurable, progressive diseases, and it is to address health related suffering. So you know that HIV, you know HbSAg cannot be cured. So already he has two conditions which are incurable and which can cause a lot of psychosocial somatic illnesses. So definitely this patient should be under palliative care, because it's not just his physical symptoms. His mother is obese, his wife has left him, his brother has left him, he probably has no money, so he's going to government hospital. So there's multiple things to suggest that this patient is an ideal candidate for palliative care. So that answers question 2. Does anybody want to add?
Anybody want to add anything more to this, what Madam already told?
So that's basically the definition of palliative care, that it is meant to address health related suffering of the patient and the family, for those, especially those who have chronic incurable conditions, which our young man fits into it, and poor fellow is only 45. So he's young to be so critically ill. So that's definite indication for palliation. Now coming to this chest pain, shall I go on?
Please, madam.
Yeah. Anybody has any comments on chest pain or shoulder pain? What could be the cause? Yes, madam, you can.
So what is the X-ray of this patient show? That was what was important, because it could all the right shoulder pain and chest pain. Is it something else? Radiation? So these the things you can think of is, first, because he's immunosuppressed and antiretroviral positive, they very common have chances to have even malignancies. So what is the X-ray show?
X-ray showed you only the apical part is little bit hazy on both the sides.
So that was confirmed tuberculosis?
Yes, madam.
So then there, okay.
They have done this PCR test also.
Right. And when you say severe pain, was it like muscular pain? Could you describe the pain?
No, madam.
Pain was so much that he couldn't sleep.
Is completely dragging type of pain and is not able to sleep, and on the movement of the limb he is not getting any relief.
Right.
He
So
is night time he is
not a smoker.
Squeezing the he completely squeezes his limb.
Right. So in terms of this, I think obviously the examination will make a difference, but obviously you can give morphine, because morphine is excreted by the kidney. And if we don't, if we, in both conditions, both renal and even if the kidney the creatinine is deranged, you can still use morphine safely. You have to only increase the frequency of morphine. If the palliation and symptom control is important, you can still use morphine cautiously. So always the caution and the mantra with palliative care medicine is start low, go slow. So there's no fixed dosage. It is not like antibiotics. You have to start low and keep increasing till the patient gets relief, and you titrate the other parameters is not going haywire. So if you know creatinine is deranged, then obviously you should increase the frequency. Sunil, you're probably even better equipped than me to answer this question.
Dr. Narendra, I understand that you don't have much details on pain description. Do you have anything more to say about pain?
Pain is continuous in nature.
Okay.
And is gripping in nature, and it is increasing, the severity is increasing by the night. And he is squeezing his hand to get some relief, but which he is not getting, and it is disturbing him so much that he is not able to sleep.
It's not radiating to the arms.
Radiating to the arm, right shoulder and arm till the half, like just between the shoulder and the only upper arm only.
Upper arm. To the elbow.
Elbow.
Yeah. Okay. So this pain looks like more of a neuropathic pain because it radiates, it is a combination of nociceptive as well as neuropathic pain because it also radiates to the upper arm, which says it has a neuropathic component. So, is there any problem with his spine? Uh,
It's okay, normal, sir. Spine is
no.
normal. He's able to walk. But when he came to my chamber, he's like, very depressive manner he walked like.
So we have a physiatrist with us. Let's take her opinion also.
So this neuropathic pain, then we have to check if it is a radicular type of pain, which is radiating from the cervical region towards the right upper arm. Maybe it's C5 radicalopathy is something. You find it like that. The X-ray cervical scan suggests. Is there any spondylotic changes or was the DB confirmed only or the apical region or any other?
Pain is also there, madam. Right side chest pain is also there. Below the clavicle till the nipple.
Murthy sir was going to say something.
I suggested Narendra to use gabapentin and nortriptyl combination 1BD. Add along with the drugs.
Okay. Thank you. In this patient, morphine is not contraindicated. Actually, we can use morphine for nociceptive as well as neuropathic pain. Morphine is partially sensitive to neuropathic pain also. So maybe you can start on morphine, 5 milligram Q for H and SOS, and you can titrate it according to the pain relief. And for the neuropathic pain component, the WHO 2019 essential drug list, they have declined to include gabapentin and pregabalin in their essential drug list because they say that there was some fraudulent evidence which caused them to take out gabapentinoids from the essential drug list. So we have to be careful. So maybe we can use the tricyclic antidepressant more.
I think the one essential thing that we need to focus is that the doctor has clearly said that patient was depressed. Sometimes that mental state itself can worsen the physical symptoms. So counseling, I don't know whether there's access to counseling in a government setup or a referral to some psychotherapy or some support, because his overall life looks so gloomy, not just health, even otherwise, socially, financially, the kind of support at home. So I know we cannot solve everything, but it is our onus to at least address it, ask him, and therefore refer to people who can at least help him, at least cheer him up in a manner that we can in that socioeconomic society. Because I think this is something that as doctors we never go beyond, whether he is able to cope with his illness. What are we doing for that? I know we don't have solutions, but at least we need to ask, is there something I can do to make you feel better?
Yes, I second that because this patient, if he is in clinical depression, he also need to be treated for clinical depression, which is very important because in depression, the psychological problems can sometimes manifest as the somatic symptoms. And even that depression, as Madam told, the physical symptoms can be aggravated in presence of his social circumstances. So
what we call as total pain, right? It's not just the physical pain, it's everything, which is famously quoted again by Dame Cicely Saunders. It's a concept of total pain, which I'm sure all of you are aware of, but we really need to see the patient as a person and therefore start addressing his issues.
Can anyone enlighten us regarding the drugs, whether this HIV medication which he is using on tenofovir, epivirazine, shall we have to change it or shall we have to continue the same?
With respect to what,
Is
sir?
there any suggestion so that I can again call him back and discuss with the District AIDS Control Society that because of this alkaline phosphatase is increasing, shall we go above that tenofovir? Because
Dr. Narendra, we have a family person here from US, Theo. Theo, what would you recommend regarding his HIV medication?
HIV medications.
Yeah.
Well, I mean, with depending on access of what medications are available, generally with efavirenz, that generally causes more CNS activity. So there could be some benefit with switching, but I don't think he has renal dysfunction. So tenofovir doses of, usually tenofovir is combined with, what is that? Tenofovir with another NNRCI, but usually I wouldn't prefer to use efavirenz with that just because there can be some CNS components with it. The other thing I do want to mention though is if you do decide to start the patient on morphine, keep in mind of his current medication since he's also on Ultraset, which is also acts as SNRI and opioid, so you aren't doing duplicate therapy. And in regards to his neuropathic pain components, in addition with clinical depression, you can consider an SNRI, which would help with the neuropathic components while helping improve his mood.
I think in a nutshell, this gentleman has to be on a multidisciplinary team with the respiratory physician for tuberculosis, with the infectious disease for the HIV, with the surgeon for the ascites, with the psychologist, and with somebody who's going to monitor all his drug interactions and relations. But what happened to the bleeding PR?
Dr. Narendra. Dr. Narendra, please unmute yourself. Yeah.
The bleeding PR?
Dr. Narendra?
yes, I'm trying, sir.
Yeah. Dr. Rajam was asking what happened to bleeding PR.
Yes, sir. Am I audible now?
Yes, you are.
So bleeding PR is first degree hemorrhoids, which we can treat medically.
Okay.
And since there is liver condition with increase of alkaline phosphatase, it is not better to intervene and do surgery. We should only control it with the drugs and for the pain, we need to put some local applicant like some smooth or some Dibosil or something like that. We need to write some drugs like Tancodi, Dibosil, calcium dibosilate.
The only reason I asked was because quantity of bleeding PR can also contribute to blood loss, anemia, and general debility further.
I think he was more worried after he saw the blood in the stools.
Obviously.
Because he was the fear of death has come onto him, and that is why he came out of the government setup to the private sector.
He definitely needs counseling and psychotherapy. A lot of his issues will be addressed because, thinking about death, it's quite scary for a young person to already start thinking about his death. So it's very clear he needs a lot of psychological support as well as social support.
Yes, madam.
Yeah.
So you would be the better person for managing this patient rather than sending to somewhere else because you already have a palliative care approach and
absolutely.
Yes, sir. I have taken up. I'm dealing the case right now. He came to me around 1 week back. So I started him with 5 mg. Now he's able to sleep and he's able to eat now. And we reconciled the patient's family. His brother came down. We had a group discussion with them, and we called their peer groups also. His cousins and all these people, they belong to fisherman community. So I called those leaders also. All of them came to our hospital. We had a group discussion to support him. So now again his brother is ready to move in and support him. Though there is a little bit resistance from the brother's wife because she was kicked out, and again she can't just come back just like that. So there should be some reconciliation regarding that. And now after 1 week, yesterday only, he came back to me and he said he's eating good and taking fruits and all these things, and he's getting a better sleep now. After the counseling session, they have improved and the family is with good gratitude. Let's see what the future is lying for him, because he has got multiple problems. First of all, he need to complete the tuberculosis course, because I am more worried about the pill load, because he has to take so many pills. So I'm thinking about how to reduce one by one. So by step approach we are going, because because anti-tuberculosis drugs there are it takes a lot of energy from the body to dissolve, and the protein supplementation should be good. Once he's psychologically okay, then only he can take some good meal with protein. So even supplementation with some protein powders also, once he feels well only, then he can take anything. Otherwise, like if he is depressed, I don't think so that he can cope up with all these symptoms.
But you've already done the bigger chunk and treated him marvelously. Only one comment: the doses of TB treatment seem suboptimal. I'm not sure what his weight is. So the 175
is around 55, madam.
Yeah, so 55 kilo man needs 5 milligrams per kilogram INH, 10 milligrams of rifampicin, 15 of ethambutol, and 25 of pyrazinamide. He's not getting that. Is it because of the liver?
Yes, ma'am. Most.
It's dangerous to give a suboptimal AKT. No AKT is better than suboptimal AKT, because no AKT doesn't kill the bacteria and doesn't. It's like you're neither here nor there.
Yes.
It's better. See, this is I think one of the issues of management of tuberculosis, and the reason why it is where it is in India is because of the fact that we can't do suboptimal treatment. It's okay if the patient doesn't take AKT for 2 weeks. You wait till you can introduce one by one drug, but full optimum drugs. Because suboptimal drugs will make your MIC low and the drugs will still multiply. So AKT treatment, because AKT TB is the only thing that can be cured in him if he's drug sensitive. So that is something you should take help of a respiratory physician in your and treat, because that is the one thing you can cure him, and that's the one thing that he can give to others even without him wanting to, because it's a communicable disease.
Yes, ma'am.
So as a community, this thing, it's best to treat that aggressively, because that is something that is curable.
Thank you, madam.
Yeah, thank you. Thank you for the case also and the good discussion.
So this patient, there is no doubt that this patient comes under palliative care because we have to look at the health-related suffering. So this patient has all the domains of suffering: physical, psychological, social, financial, and even spiritual domains. So this patient needs to be under palliative care and should be given palliative care in a proper way. And the causes of chest pain and shoulder pain, we couldn't find out much reasons, but we have to investigate more and find out if there is any problem with the spine. And definitely we can use opioids, because this patient's pain is not controlled with ultrasound. So we will move on to the next step, where morphine can be used, and you are giving morphine for the patient. And happy to hear that he is improving. So thank you for presenting.
Thank you very much,
such
sir.
a story. Thank you, madam, for being with us for this important symptom. And
sorry for the initial faux pas.
Yeah, it's okay.
Thank you.
So, thank you all for your active interaction.
So we can see you on next week with a topic on wound management taken by Sister Shiva. So I've shared the feedback link. Give it a minute, do it, and then only leave the meeting. Thank you all for joining in. We'll see you next week. Bye.
Thank you for the opportunity. Bye.
Thank you, ma'am. Bye.